Our next topic is anemia. Anemia, we know it is characterized by deficiency in the number of the red blood cells, or when there is a decreased amount of hemoglobin in the blood that leads to reduced capacity to carry oxygen to the body tissue. Now, WHO has established the guidelines for diagnosis the anemia based upon the hemoglobin content. For the adult male, a hemoglobin level less than 13 gram per deciliter, it is considered evidence of the anemia. Whereas for the adult non-pregnant females, a hemoglobin level less than 12 gram per deciliter, it indicates anemia. However, in the pregnant females, a value less than 11 gram per deciliter, it is considered evidence of anemia. So when it comes to classify the anemia based upon the kinetic aspect, we use a system that is known as the kinetic classification, that is centered around the reticulocyte production index, that is, we also called it as RPI. The anemia, they are broadly categorized into two types: hypoproliferative or hyperproliferative type. What do you mean by hypoproliferative anemia? The hypoproliferative anemia, they occur due to issue in producing an adequate number of red blood cells. So these problems, they can be from acquired nutritional deficiency or systemic disease affecting the bone marrow ability to produce red blood cells. So when we talk about RPI in hypoproliferative anemia, its value is typically less than 2.5. On other hand, hyperproliferative type, example is the hemolytic anemia, that involves, we know hemolytic anemia, there would be increased destruction of the red blood cells. So this anemia, it can be either congenital, meaning present from the birth due to issues like in the red blood cells membrane, enzymes, or globin chain. So in hemolytic anemia, the RPI is higher than 2.5. That indicates an increased production of reticulocytes in response to anemia. So the higher RPI indicates that the bone marrow is trying to compensate for the loss of the red blood cells by producing more young red blood cells. In our country, nutritional deficiency stands out as the leading cause of the hypoproliferative anemia in both adults and the children. The inadequate intake of essential nutrients like iron, vitamin B12, folate deficiency, they contribute to this form of anemia. Now, what are the clinical presentation of anemia? It can vary upon the several factors, including speed at which it develops, severity, and age of the individual. So suppose a patient came to your clinic with anemia. So how can you diagnose that? The patient would often complain symptoms like decreased work or exercise tolerance, shortness of breath, palpitation, fatigue. So here, as the hemoglobin level drops, the impact on the individual physical capacity become more noticeable. So hemoglobin level falls below the 7 gram per deciliter. So there is marked reduction in the exercise capacity. The older individual with cardiovascular disease, they might experience symptoms like angina or heart failure due to the anemia. So what is the main classical sign of anemia? So remember, the pallor or paleness of the skin and mucous membrane, it is the classical sign of anemia. So this paleness may be first manifested in the palms of hand, while the crease may retain their normal pink color until the hemoglobin concentration drops below 7 gram per deciliter. Well, the anemia, it can lead to changes in the skin, nails, and hairs. The hair would become thinner, they would lose its luster and even turn grey, especially in case of pernicious anemia. The nail may lose their shine, they may become brittle, and they commonly seen in chronic iron deficiency anemia. Severe anemia can result in symptoms like headache, faintness, lack of mental concentration, tinnitus, or the vertigo. Now, what would be the history and physical examination? So, on history, you have to explore the dietary habits, especially in the young and the elderly patient, as the deficiency in nutrients like vitamin B12 and folic acid, they result from specific dietary patterns. Apart from that, you have to also take the drug history, inquire about the medications that could potentially cause bone marrow, depression, or autoimmune hemolytic anemia. The past medical history, conditions like a gastrectomy or ileal resection could indicate B12 deficiency anemia, while the menstrual and reproductive history could help to assess the iron status. Other are the occupational history. You have to assess exposure to the occupational hazards like welding, painting, or dyes that might lead to exposure to toxic agents affecting the bone marrow. You can also take the family history. Note any family history of anemia, jaundice, gallstone, or splenectomy, which could give you a hint at inherited hemolytic anemia. Apart from that, what are the physical examination that you can do? The first of all, check for pallor of the skin and mucous membrane. So you have to note the pallor. Apart from that, you can see the specific sign like angular cheilitis and chylomicria that might indicate the iron deficiency anemia. The hyperpigmentation of knuckles might suggest megaloblastic anemia. Presence of jaundice with pallor might indicate hemolytic anemia. Examine for the splenomegaly that could suggest various conditions ranging from infection to hemolytic disorder or even malignancy. You can also check for the tenderness of a bone, especially the sternum, that could even suggest acute leukemia. Skin findings, petechiae and purpura might indicate marrow aplasia or infiltrative diseases like leukemia, lymphoma, or myeloma. Neurological findings, investigate the patient presenting with the neurological symptoms for potential early changes of megaloblastic anemia, especially in the pure vegetarians. Apart from that, you can even do laboratory investigation, a complete CBC count that would provide about red blood cells indices, hemoglobin level, and other blood cell count. Reticulocyte count, they will evaluate the bone marrow response in producing red blood cells. Peripheral blood smear that can reveal abnormalities like presence of schizocytes that are just the fragmented red blood cells. So the first is the reticulocyte count. It is a vital component in assessing and understanding the body response to anemia. So it will provide valuable information about the rate of the red blood cells production in response to decreased red blood cell level. So how can you perform a reticulocyte count? You can perform either manually or by automated method. Manual method involves staining blood smears with supravital stains like cressyl blue or new methylene blue. Manual count of these stains under microscope can provide a measure of reticulocyte percentage. Apart from that, you can use automated method. Automated cell counters and flow cytometry use fluorescent dye like thiazole orange that binds to RNA in the newly released cell in the red cells. That offers more accuracy and efficiency in counting the reticulocytes. Now, what does the automatic reticulocytes counting would provide? The first they would provide information about reticulocyte hemoglobin content. So that indicates the amount of hemoglobin that is present in the reticulocytes. So that would reflect their maturity and potential to contribute to oxygen transport. Now, what are the parameters that are derived from the reticulocyte count? The reticulocyte production The reticulocyte production index, that is RPI, this index is important between differentiating between the proliferative and hyperproliferative anemia. You can also check the hemoglobin level. Hemoglobin level less than 10 milligram per deciliter might cause symptom during exertion or in low oxygen condition. Level below 7 gram per deciliter can lead to symptomatic anemia even at the rest. Loss of pigmentation can be indicative of the severe anemia. Now the peripheral smear, you will see microcytic and hypochromic red blood cells that might suggest iron deficiency anemia. What do you mean by term microcytic? These terms refer to smaller than the normal size of red blood cells. So when you view them under microscope, microcytic red blood cells, they would appear smaller than the average size. So this characteristic feature is often associated with a condition where there is impairment in production of hemoglobin or certain nutrients or deficiency in the certain nutrients required for the red blood cells development, such as iron, leading to smaller cell size. Other is hyperchromic. Hyperchromic refers to decreased amount of hemoglobin that is present within the red blood cells. Normally, the red blood cells have a red color due to hemoglobin, which carry oxygen. In hypochromic, there would be reduced hemoglobin content that would cause the cells to look more pale or less red than usual. So this is often associated with condition where there is insufficient iron associated with the condition when there is insufficient iron available for the synthesis of hemoglobin, leading to less hemoglobin content within the red blood cells. Other is the mean corpuscular hemoglobin concentration, that is MCHC. So MCHC less than 32%, it is consistent with the hypochromic cells. So the mean corpuscular hemoglobin concentration, it is measure used in analysis of red blood cells that provide the information about the average concentration of the hemoglobin within a given volume of the red blood cells. So it is a part of the complete blood count test and it is reported in gram per deciliter. Apart from that, the raised platelet count may indicate bleeding or in some cases might be reactive response to anemia. Pearl's Prussian blue technique, it demonstrates the empty iron stores in the bone marrow, supporting the diagnosis of iron deficiency anemia. Apart from that, you can check the serum ferritin level. The serum ferritin level, it refers to amount of ferritin, that is a protein that stores iron, that is found in the blood. We know ferritin, it serves as an indicator of body iron stores. So measuring this serum ferritin level, it is important component in evaluating the iron status, especially in diagnosing the iron deficiency anemia. So the low serum ferritin would reflect diminished iron stores, so typically indicating the iron deficiency. Level less than 12 mcg per liter are typically associated with iron deficiency anemia, and value that are above the 80 mcg per liter, they usually rule out iron deficiency. Apart from that, you can check is iron absorption and total iron binding capacity. The iron absorption refers to the body ability to take in and utilize iron in form from the diet. Normally, the small intestine, it absorbs iron from food into the bloodstream. So this iron absorption, it is influenced by various factors, including the dietary intake, the body iron stores, and the body need for iron. The total iron binding capacity, it is measure of maximum amount of iron that can be carried out in blood by the transferrin, a protein that transports iron throughout the body. The transferrin, it is responsible for binding and transporting iron to various tissues for use. So TIBC represents the total capacity of the transferrin to bind with the iron, and it is expressed in microgram of iron per deciliter of blood. or in micromoles per liter. It indirectly assesses the amount of transferrin that is available for iron binding. So when the iron levels are low, as in iron deficiency anemia, there is increase in the amount of transferrin available to bind with iron. So that is why here the TIBC increases. The increased iron absorption and elevated TIBC, they are characteristic of the iron deficiency anemia. Apart from that, you can use chromium labeled red cells that are used to measure the blood loss into the GIT tract and identify the source of bleeding. The serum transferrin receptor proteins, it is a marker that is used to assess the iron status in the body, particularly in diagnosing the iron deficiency anemia from other type of anemia. So transferrin receptors, they are proteins that are found on the surface of cell, particularly on the cells involved in iron metabolism like the red blood cells precursors in the bone marrow. So these receptors facilitate the uptake of iron bound transferrin into the cells, particularly the erythroblast, where iron it is utilized for hemoglobin synthesis. So serum transferrin receptor proteins, so it is a form of receptors that is released into bloodstream, and its level in the blood can indicate the rate of erythropoiesis, that is the red blood cell production, and reflects the body demand for iron. So increased level indicate increased iron demand, and they are seen in conditions like iron deficiency anemia. Apart from that, we can see is the mean corpuscular volume. The mean corpuscular volume measures the average volume or the size of red blood cells. It is expressed in femtoliters. So low MCV, that is less than 80 femtoliters, indicate microcytic red cells smaller than the normal. It is often seen in conditions like iron deficiency and thalassemia. The normal MCV, the value is 80 to 100. It represents the normocytic red blood cells with the normal size. It is seen in anemia of chronic disease and hemolytic anemia. The higher MCV, it signifies the macrocytic red blood cells, and it is seen in vitamin B12, folate, and certain medications like methotrexate. The red blood cell distribution width, it measures the variation in the size of red blood cells. So high red blood cells distribution width, it indicates increase in the variability in the size of the red blood cells. It may be seen in conditions like iron deficiency anemia, early stages, vitamin B12, folate deficiency, thalassemia. So MCV and RDW, they help to classify anemia based upon the red blood cell size and variability. That helps us to give differential diagnosis. Apart from that, you can do is peripheral blood smear, that is a manual examination of sample of blood under the microscope and remain. It is an important diagnostic tool. So what are the key findings? First of all, you would see morphological findings in red blood cells are the microcytic hypochromic red cells, so indicate smaller than the normal and paler red blood cells. So they are suggestive of condition like iron deficiency anemia or thalassemia. Apart from that, you can see macrocytic red cells with ovelocytes, that is they are larger than the RBC, they are larger than normal with the oval shape. They are seen in megaloblastic anemia and B12 or folate deficiency. You can also see Burr cells, echinocytes or acanthocytes, spur cells. So echinocytes, they exhibit spiky appearance, while acanthocytes, they have a irregular spiky appearance. So they are seen in condition like uremia, severe liver diseases or A beta lipoproteinemia. Apart from that, you can see target cells, RBCs with bull eye appearance or center pallor surrounding by a ring of hemoglobin. They are the target cells. They are seen in liver diseases, sickle cell anemia, thalassemia. The schizocytosis are the fragmented RBCs. The fragmented RBCs, they are often associated with systemic diseases like TTP or DIC, etc. Spherocytes, they are the small dense spherical red blood cells lacking central pallor. They are suggestive of conditions like autoimmune hemolytic anemia or hereditary spherocytosis. So what is the importance of peripheral smear examination? It helps in identifying the blood disorder. So it helps to detect the abnormalities indicating of specific disease or organ dysfunction. It also helps to facilitate the diagnosis of parasites like malaria, filaria, leishmania, especially when using a thick blood smear. The next is the bone marrow examination that involves the bone marrow aspiration and biopsy. So it is a procedure that is used to evaluate the cellular composition and architecture of the bone marrow. So what are the indication of bone marrow examination? So when you find there is suspicion of underlying hematological disorder like leukemia, lymphoma or any malignancy. In case where the hyperproliferative anemia is suspected, a bone marrow biopsy may be necessary to rule out aplastic anemia. What are the components of bone marrow examination? It involves the extraction of liquid bone marrow. So that involves extraction of liquid bone marrow using a needle to assess the cellular composition and provide the material for morphological examination. So the bone marrow biopsy, it obtains a solid bone marrow tissue and it is evaluated for architecture, cellularity and further histopathological examination. Apart from that, you can do is additional test with the bone marrow samples, flow cytometry in order to diagnose the hematological malignancy. The additional test that you can perform is sickling test that helps to detect the presence of sickle hemoglobin, comb test that can be done to identify the autoimmune hemolytic anemia by detecting the antibodies attached to the red blood cells. Cold agglutinin test that evaluates the presence of antibody that causes red blood cell agglutination in cold temperature. Apart from that, other test could be osmotic red cells fragility that helps to assess the fragility of red blood cells in osmotic solutions, example in the glucose 6-phosphate deficiency. Apart from that, you can also perform is serum iron binding capacity, serum ferritin level, marrow iron and serum transferrin receptor test, and measuring the serum B12 and folate level. The urine examination, you can look for various indicators like proteins, pus cells, red blood cells, urobilinogen, and hemosiderin, providing clue to cause of anemia. Stool examination helps to diagnose the occult bleeding, especially in the iron deficiency anemia. Gastrointestinal endoscopy may be required in iron deficiency anemia to investigate the bleeding or underlying malignancy in the elderly. The iron replacement therapy, ferrous sulfate 200 mg thrice day containing 60 mg of elemental iron that can be given orally. So it is safe and cost effective. So expected rise in hemoglobin is about 1 gram per deciliter per week or 1% per day. And there would be rise in reticulocyte count. You have to continue until the hemoglobin normalizes and for 6 to 8 months to replenish the iron stores. Alternative oral preparation that you can give is ferrous fumarate, ferrous gluconate, polysaccharide iron, carbonyl iron. Parenteral iron therapy. So in patients who are unable to absorb the iron orally or intolerant to oral therapy, intramuscular iron 100 milligram increases the hemoglobin by 4% and you have not to exceed a dose of 2.5 gram. The additional parenteral iron preparation are the sodium ferric gluconate. You can give IV in normal saline over 1 hour and not exceeding above the 250 milligram per day as that can lead to adverse reaction like the hypotension. The other consideration of the oral therapy, they are the you have to get through with the underlying cause of the anemia. Additional treatment might be necessary like vitamin B12, treating chronic illness or stopping the medication that is causing the anemia. The parenteral iron therapies like iron sucrose that can be given 100 mg in 100 ml of normal saline infused IV over 30 minutes. Iron dextran. Each 2 ml contains 100 mg of iron. So initially a test dose of 0.5 ml should be given before the starting therapy. If well tolerated, subsequent dose can be given. So the oral iron therapy, it is the preferred choice due to safety and cost effectiveness. The parenteral iron therapy should be used when strongly indicated or when the oral therapy is ineffective or not tolerated. Parenteral iron therapy may have side effects including fever, chills, joint pains, lymphadenopathy, and they should be used cautiously. Regular monitoring, it is essential to assess the response to the iron replacement therapy.